Well, it's a great pleasure to be invited to talk to you today about the digitisation of health and what goes into it, and we'll use the example of St Vincent's as a particular case in point just to illustrate roughly what's happening. But the whole digitisation of health is a very interesting phenomenon, and really when you compare health with other industries, this is where we find ourselves. Traditionally, the investment in health has been very low, normally less than 1% of a budget, whereas when you compare that with, say, insurance or banking, they've got between 8 and 10% investment, and it's ongoing and very, very hard-nosed. The way that we practice medicine is not too different from when medicine was invented. You can see it all in the 20s and 30s and 50s and 70s, and most of our processes are very much the same, although, in fact, what we are able to do is increasing fast. And it is also fair to say at the moment that the digitization technologies that are now available are accelerating far faster than we can actually implement them at the moment. So we have a great deal of catching up to do in that regard. It's also true that the rate at which technology is introduced to healthcare is held back, is perhaps the polite way of putting it, because the whole of healthcare delivery in most developed countries is politically driven rather than competitively driven. And as we've heard this morning, in order to be really good, to adopt technologies in a meaningful way, you have to really want a sharp competitive edge. And that competitive edge at the moment is not found in the way that healthcare is delivered. And the final disadvantage for us is that because of the lack of investment, we start off from a very low background. Very slow Windows, old versions of IE, meaning that any kind of current software development becomes too far ahead of what we're able to implement easily without a significant investment in the base infrastructure inside healthcare organizations. Now, one of two historical ironies that I'll point out to you today. The first Chinese text on medicine was written in the year 2600 BC by a physician called Huang Ni. And he said, inferior doctors treat full-blown disease, mediocre doctors treat disease before it becomes evident, and superior doctors prevent disease. Now you ask yourselves where we are in that spectrum. So I think we have quite a long way to go before we catch up with that wisdom. And undoubtedly, when you think about what technology ought to be able to do for healthcare delivery, think about the most advanced taxi firm in the country. It doesn't own a single taxi. Think about the most advanced real estate company. It doesn't own a single piece of real estate. And think about the most advanced telecoms company. It doesn't own one piece of switchgear, one piece of infrastructure at all. It's all IT driven. So what then can we do with technology in health? And if we're going to get anywhere near Huang Ni's aspirations, then we have to think about not replicating what we currently do, because if we replicate what we currently do technically, then we will do it as badly but much more quickly, which is even worse. So we have to be able to aim towards preventing disease at the outset, and that is by getting into schools, making it important for children that they understand that their health is important, using the technologies that are emerging now for prediction so that we can match genetic and genomic with our ordinary day-to-day health data and prevent diseases from happening by prediction. And motivation, above all motivation, get people to really want to stay well. It's true that countries which choose to involve in investment in health, in the end, prove far more advanced after 18 to 20 years than those that invest in infrastructure. So we need a paradigm shift because we have this technical tipping point where we can now begin to look at health in a completely different way and do it in a holistic way rather than just looking at individuals. Now, this piece of stone is pretty famous. We think that the Department of Health and Social Security, now affectionately known as the Department of Stealth and Total Obscurity, have embedded little bits of those stones beside these plaques. And every time they go into work in the morning, they start talking technobabble in an amazingly convincing way. and that means that we've spent £12 billion over the last 10 years and maybe find ourselves about 2 years ahead of you. So we do, however, have a great deal of experience to offer in terms of what you might not do rather than what you might do. To set the scene from an Irish perspective, it is clear that the value of investment in health and technology in health has been understood, and so we can see the beginnings of investment here just emerging, so that there is a real desire to have a proper strategy. There's a mandate from the government to get on with it because they see it as very important. They have understood, certainly from the English experience, that unless you seriously involve clinicians of all kinds, nurses, doctors, paramedics, healthcare professionals of all sorts, unless you involve them at the outset and understand what they need, then you're in danger of providing the wrong thing. There is certainly an enormous willingness to adopt. Most of the junior doctors I come across have all got stuff on their own devices, and they're saying, for heaven's sake, what are you doing? Give us stuff. They do their own handovers medically on WhatsApp because we can't do anything for them. So we've got quite a long way to go. All of that said, we should resist the urge to simply just implement, because if we're really going to get any kind of value of what we're doing, we have to look hard at the way we work, the way we deliver healthcare, change it so it's the most effective way of doing it, and only then embed that in solid technical process. So the end goal, you will not be surprised, much as I've just said, from a population well-being point of view, it's focus on prevention, it's empower patients to have control over their health, give them a feeling that they own it, and improve outcomes so that we do a great deal better in treating than we currently do. From a services perspective, we need to make it cheaper to deliver, we need to make it much more safe, have much fewer adverse events, and give the clinicians the ability to spend more time talking to their patients and being with them than just looking at technology. And the economic benefits, I think, are fairly self-evident from what I've just given you. So, just by way of introducing what's going on at St. Vincent's, I'm showing you here what HSE are calling a persona. HSE have had the insight to not procure systems by having obscure output-based specifications, but they've asked everybody involved in healthcare delivery to dream up some scenarios which are realistic for you, so that the successful supplier can show that they can deliver these scenarios. And these scenarios vary from patients to nurses to doctors to IT managers to general managers in the hospital. Everybody can say, well, this is my everyday world. I want technology to help me like this. Now, poor Alice has had a bit of a bad day. She's a retired teacher. She's 68. She's diabetic. She has pets. She is able to look after herself in the main. However, out shopping, she collapses and falls over, and that's because her leg ulcers, because of her diabetes, have become infected. The pets have got to them. That's given her septicemia. She's fallen over while she's shopping because of diabetic coma. She's broken her wrist, and she comes in a really rather bad state. The systems now in place enable her to be triaged very quickly, almost as she's coming through the door. And while she's not an immediate situation, she certainly is very urgent and needs to be seen pretty quickly. She's taken to a bed, obviously, and the whiteboards up on the wall in the ED department are able to show that the staffing level is enough, the clinical cover is enough, we have space, and by reference to what they think is wrong with her, they can predict that they can look after her adequately both now and when she's finished inside ED. Even down there, the wrist fracture can be x-rayed, everybody understands precisely what it is, and as a result of that, an appropriate referral can go electronically from the Vincent's application to summon the orthopedic team, summon the diabetic team saying that they've got an urgent patient that needs review as soon as possible. And all of that can be done using mobile applications, and it's a very, very much more efficient way of working. So the components of digitization are an individual identifier, with HSE has begun to roll out in Ireland, a quick triage, which has got decision support beneath it, therefore you've got confidence in its output. The fact that she's allergic to something means that even though she can't tell you what's going on, you don't put up an inappropriate antibiotic for her septic ulcer. And the rest of these things you can see as you go through it. The whole process that you would normally expect to be rather difficult, paper-driven, take time, prone to error, with lost results, illegible handwriting, and even if you could find Alice's original notes, then if you rely on the patient to tell you what's going on, you're going to be in trouble. I remember, as an aside, the last outpatients I did, 2/3 of the patients arrived without notes, and I was utterly dependent on their memory to tell me what was wrong with them. So the advantages of the implementation of this new system in St. Vincent's mean they have a huge advance over the way that they currently practice, and they can do it with demonstrable outcomes of benefit and a huge benefit to the patient. To put that in sort of perspective, for St. Vincent's, they have something like 50,000 patients coming through their ED department every year. They had an aging system, which was about 14 years old and no longer fit for purpose in the current era. In order to change over to the new systems, they had to do a successful migration of data, and they migrated over 16 million records in 4 or 5 hours, very successfully with no errors. And also 90 staff had to be trained quite quickly to enable them to get the benefits out of the system and be up and running when it went live. The primary benefit that the director of the department, Professor John Ryan, says he most appreciates is that he's got an immediate handle on who's going through, what the staffing level is, what the acuity of the patient is, the availability of the rest of the resources inside the hospital, so he can do immediate planning and crisis resolution if that's necessary. So the benefits, and these are those declared by the department, they're not put up by us, is the mobile care makes working so much easier. You have exactly what you need in front of you in your hand. You've got a complete handle on where the patients are and what's going on. And from a management point of view, you can produce an hourly report on what's going on. It's much safer for the patients. The inbuilt integrated care pathways will keep a patient on a clinical straight and narrow, if you like, with little deviation unless that's authorized. There are alerts within the system that if simple parameters go off, the right person can be alerted and the right person can be called, and it goes onto a work list for a clinician to make sure that it's done. And that above all, that the right data is available at the right place and at the right time. And as John Ryan said, as far as he's concerned, just the ability to improve the performance management is one of the biggest benefits that the whole system can bring. So back to another historical irony again. This is the Ötztal Pass, which is the pass over the mountains between Italy and Austria. And one of the little gifts of global warming was that inside the ice up there, when it melted, a body appeared. And that body was carbon dated to 3,200 BC, which is over 5,000 years from now. And in order to try and find out why he died, both the Austrians and the Italians fought over who would do the first CT scan. The Austrians found nothing. The Italians found this little arrowhead underneath the poor man's shoulder blades. But in so doing, they looked very hard at the body and they found these tattoo points that you can see here. Now, the CT scan also proved that the man had gallstones and he had a stone in his kidney. And the tattoo points not only recorded that fact, but they also corresponded exactly with the Chinese acupuncture points, which would be used now for treating those diseases. The only problem is 3,200 BC was 2,000 years before Chinese acupuncture was invented. So we've had a whole health system come and go with sophisticated treatments and the ability for the patient to carry their record from place to place to inform the doctors. Can we do that now? Thank you.